Hello, my name is Snail Desai, and I'm going to go over COPD treatment mechanisms as part of this NAPLEX review course in the respiratory section of it. Take a look here. These are some of the topics that's covered on the NAPLEX. I listed them out here, so at least you have an idea as to what to look out for, especially on patient cases. Um, and also the medication types that's used in each of these disease states. Um, I just listed here some of the differences between like COPD and asthma. Asthma is typically like a reversible disease. You can see here in the diagram on the left how like in the airway tube or the wall within that hollow area, you can see how in a normal airway there's nothing really preventing the air from moving from one part of the lungs and then moving it between like the where you're breathing out and in and that part of the area. So you can see some of these pathways where this is actually hollow, and when there's asthma symptoms, you could see a little bit of mucus that's kind of blocking a little bit of the airway. So sometimes you might have like shortness of breath. It probably might have been because of mucus. Some of these things are really like easily reversible. Just clearing up the mucus is one way of looking at reversible asthma disease. Um, it is usually trigger based, so like things like if there's a cold or if there's an infection of some sort, um, maybe some allergic symptoms, allergies. So any of those things can kind of trigger like the asthma based um, symptom or asthma disease. So these things are possible that may trigger or result in asthma over time, especially where COPD, you can see here how in the lungs, the healthy um, bronchial tissues or like the alveolar part of it or things of that nature, you can see how like the healthy part is actually kind of um, all brown now because they're going bad, the healthy cells there. So COPD is a type of disease that is irreversible. It cannot be reversed, um, at least not as easily as asthma can. Um, and it's usually occurred due to most commonly for people who are smoking for long periods of time or smoking maybe 20, 30, 40 packs a day or really, really smoking all the time. They are likely to get um, like a COPD disease. And that's because all that you can think of like a cigarette, kind of like when you're smoking, you can think of like all that debris that you're just putting in through your lungs, and that is kind of blocking all of the good stuff from flowing in and out uh, through the lungs. So like air is not able to push through, and then the patient can get like shortness of breath, and other complications can emerge. Um, so it's better that um, individuals who are smoking should not be smoking it, because in later life these kind of complications can occur. So um, that's why it's important to keep the lungs healthy, um, because eventually, when these kind of complications occur, then other types of diseases may occur as well, like pneumonia, emphysema, bronchitis, and then that results into further infections, and then it can become very severe. So um, I just wanted to point out some differences here, maybe just for educational purposes, just so you know and have a general idea of the main difference between COPD and asthma. Um, that's typically it here. So when it comes to COPD treatments, some of them are usually taken like a um, together in combination or as by itself. So like one of the medication that I'm going to discuss um, in this presentation is the long-acting muscarinic antagonist. And you'll see that is actually the first one at the top. Usually, typically, that's a first-line therapy. Now, I would still recommend that you look through your notes and check the guidelines. It may have changed. So, but Dilemma is one of the medication classes that you would see as being used for COPD. You would not see that typically used for asthma. So just know the differences here between the asthma and COPD in terms of what medication is used. Um, and note that some of them have a corticosteroid um, inhaler along with LABA and LAMA. So in COPD, we're not only treating the inflammation, but we're also trying to open up the airway and trying to do both of those combined. So that's why you would see all both of these here. Sometimes you might see LABA and LAMA. Typically, they do about the same thing, but this might have a more of an additive effect in bronchodilation. So, but we'll take a look at um, the mechanism of LAMA in this presentation. So LAMA is a very interesting medication. So in your smooth muscle, which is obviously the bronchial tubes, where like the lungs are and how it flows from like the mouth to the nose through your lungs. You'll see here, like I drew a diagram here of like the smooth muscle, and on top of it, you can see one of the receptors, which is the M3 receptor. Now, and then you see here in green the vagus nerve. When there's a because vagus nerve, this is an anti-muscarinic um, type of receptor or muscarinic receptor. We're dealing more with the nervous system here. So a lot of the you would see like acetylcholine being produced by the vagus nerve, and then it's released. And then when acetylcholine is released, it would try to bind to the M3 and cause bronchoconstriction. But when we use LAMA, like for example, tiotropium, when that is used, it's going to bind to M3 and block acetylcholine from binding to the M3 receptor. And so what happens here now is the smooth muscle is going to bronchodilate, or, allow airways to, move through the bronchial tubes. So that's essentially the idea of this mechanism. And that was pretty much it in this presentation. I just wanted to show you one type of medication class used in treating COPD.